Hello, and a very warm welcome to COVID-19 Updates from Singapore. My name is Caitlin Wee, and I'm a second-year medical student at NUS Yong Lu Lin School of Medicine. This webinar is the 8th in a series of 12, presented by NUS Yong Lu Lin School of Medicine, National University Health System, and Global Outbreak Alert and Response Network. This weekly webinar series will provide viewpoints and insights from a panel of leading experts in infectious diseases and related specialties and disciplines. It is now my honor to introduce you to our moderator, who is also the program director of the series. Recruited to establish an infectious disease training program in Singapore, he was the first infectious diseases head of department in the Communicable Disease Center here in 1992. He is also a visiting senior fellow of the Courage Fund at the university. Ladies and gentlemen, Dr. David Allen.
Thank you, Caitlin. Good evening and welcome to the 8th installment of our webinar series, COVID-19 Updates from Singapore. We hope this broadcast finds your family safe and well. We'll be reverting to our customary format this week. Each episode will begin with a review of regional and international epidemiology, followed by an in-depth talk by our visiting guest expert. This will be followed by a question and answer with our guest speaker, Professor Fisher, and myself, then an update of current events by Dale, and a preview of next week's guest expert. We do request that you send your questions, and we welcome your comments of how we can better serve you. Without further ado, allow me to introduce Dale Fisher, who is going to give us an update of regional epidemiology and international epidemiology. He's Professor of Medicine, National University of Singapore, Yong Lu Lin School of Medicine, Senior Consultant, Division of Infectious Disease at National University Hospital, and Chair of the Global Outbreak Alert and Response Network hosted by World Health Organization. Over to you, Dale.
Thanks, David. So, customary is right. This will be very similar to what I've presented in previous weeks. You can see over the last week, we've gone from 21st of May to the 28th of May. And again, we've gone up a little over 600,000 cases worldwide. And in terms of deaths, we're 355,000 deaths. So we're up about 35,000 as usual, or 30,000. Today, the US crossed 100,000. So more than a quarter of the deaths have been in the United States. Moving on, this is the global epi curve. There is a trend. You can see that the black line representing the deaths, which is around, I guess, over the last 2 weeks, is around 4,000 cases a day. That they are coming down. It's interesting. I'm not sure where we're headed with this. I think all the cases here probably should have been higher, in which case the epi curve would have kept going up probably to the top of my screen here and then made its way down to parallel this, unless the black line really represents overwhelmed countries, which of course is partly true. The whole number of cases thing, I think, will need to be rethought of as a metric as we start to add in asymptomatic cases, which many countries have included, but other countries aren't testing for. And also, obviously, serology is going to be a major change. So I think the death rate may become more significant than the number of cases. This is the number of, this is by WHO region, and you can see the different shapes, but largely with the case numbers going up and most of the cases either being fairly flat or in Europe really coming down, and that's really reflecting the previous global graph. In the Western Pacific region, again you can see that the shape of the curve coming off in terms of both cases and deaths. China is pausing in the 84,000s. Singapore's the second most affected country on these counts at 32,000, about 4,000 a week, a bit similar to the Philippines. Southeast, and just to point out, what we've mentioned in previous weeks as well is as the numbers come down, we're going to get a lot more granular, and you're going to see these clusters. And this was South Korea just reported its biggest day for some time in 49 cases. This is in an e-commerce facility, and it's probably related to the same cluster which affected the nightclubs, but that's not confirmed yet. But this clusters creating new clusters through no obvious immediately obvious transmission chain, I think, is what's going to cause us a lot of problems going forward. Southeast Asian region, you can see the case numbers climbing here. Now 8,000 cases per day with around 200 deaths. So that's not a bad ratio. India driving this with about 50,000 cases in the last week and 1,000 deaths in that same time. And here you can see what the curves of India look like, all these countries on the incline. Whereas Europe continues to go down. Russia is the main driver. This is about 10,000 cases a day and about 1,000 deaths in the week. UK is about 2,000 deaths in the week. So clearly in that later phase of the outbreak. And for interest sakes, Sweden is now up to over 4,000. So chugging along at between 50 and 100 cases a day, dying with their strategy. The Eastern Mediterranean region, very interesting, increasing cases, but a fairly flat number, just 200 deaths a day in the whole region. And you can see that this is being driven really across the board. Lots of countries with numbers going up. The shape of the curves is quite interesting. Notably, the ones that are being driven by the foreign worker dormitories, like Singapore, seeing very few severe cases. So there's Qatar, Saudi Arabia, Kuwait, like that, UAE. The Americas, Pan American Health Region, Health Office. Again, you can see US is the dark yellow, and the pale yellow is the one on the exponential climb. We can see this has been called the new epicenter, with US still having up to 1.6 million total. Brazil has had 120,000 cases in the last week, and both those countries are still seeing about 1,000 deaths a day. Really quite astonishing figures. And you can see here's how it looks like. I'm going to look at Brazil a little bit more later on in the show, but you can see all these South American countries and Central American are really struggling. Africa, similar to previous weeks with South Africa, with its probably superior testing capacity, I would imagine, but also challenging demographics, seeing the largest increase there. And there's the shape of those curves. So again, lots of challenging things happening in many African countries. Moving into Singapore, this is quite similar. You'll remember we're running 2 outbreaks here. This is the community numbers, which are really quite low now compared to the dorm numbers, and the red ones are the imported cases, which have obviously stopped. So interestingly of note, as those of you in Singapore will know, we've been doing sweeps of nursing homes and preschool teachers, and we're finding a few cases. So this is, you might remember I mentioned a couple of weeks ago that really these cases that were really unexpected are why the social distancing measures and things are so important, because these people are often asymptomatic or very mildly symptomatic and not connected to an outbreak, not known to be a contact, yet they can still fuel future epidemics or clusters. And as I mentioned before, this was always going to rumble on for some time in the dormitories, not taking a normal epidemic curve shape because of the various complexities in the dorm and various capacities. So, however, as I did mention in previous weeks as well, we've got a very good feeling that the ARI numbers are coming down. There's clear reports of improvement in that setting. And again, here I'll just mention the yellow being the number of cases, and these are linked and unlinked, and you can see these unlinked yellow cases, the community cases, a little knob at the end there, and that's as we started this screening. So a bit of a concern that these people still exist, or these cases still exist, representing that sort of under the radar transmission, which is the scary bit. And final slide. Well done to all the health workers. You can see the number of ICU cases and the number of deaths. So we're still in the low 20s for deaths and less than 10 ICU cases with COVID. So this wasn't exactly what we expected, but it's a very good outcome. And to talk more about ICU, I'll look forward to the rest of the show. Back to you, David.
All right, thanks so much, Dale. Appreciate that update. I want to remind our listeners to send in your questions via the question and answer tool at the bottom of your Zoom screen. We very much appreciate those, and we'll try to get to as many as possible. It gives me great pleasure to introduce our guest expert tonight, Graeme MacLaren. He's Associate Professor at Yong Loo Lin School of Medicine, National University of Singapore, Senior Consultant, Department of Cardiac, Thoracic, and Vascular Surgery, and Director of Cardiothoracic Intensive Care at National University Heart Center in Singapore. The title of his talk this evening is Managing the Critically Ill COVID-19 Patient from Oxygen to ECMO. And as a courtesy to our viewers, I just need to let you know that Professor MacLaren will communicate his subject matter, including some photographs of blood and invasive devices. And we look forward to your talk. Graeme, over to you.
Thanks very much, David. So as you indicated, I'm an intensive care physician, but I recognize that a large amount of the audience aren't. So I have to try and find a balance between getting too technical, but also just giving a broad overview of what support, what medical devices we can use to try and keep patients with COVID alive until they can recover. So I'm just going to start the presentation now. So just before I get going, I have a couple of disclosures. The largest ECMO society in the world, which is a not-for-profit organization, is called ELSO, and I'm a voting member on the executive committee. I will be discussing some of the activities that ELSO will be doing. I will be using a lot of photographs to try and illustrate various forms of life support, but I don't carry any endorsement of these products. I don't have any connections to industry. Some of these photographs are also copyrighted by NUH. So what I'm going to try and do in the next 15 to 20 minutes is just go through the various options of life support that we have available in intensive care to try and keep patients alive. Most of the focus of this will be in adult patients. I think COVID-19 in children hasn't received quite enough attention, and now in the last few weeks we are seeing problems emerge in the pediatric age group, which I will touch upon at the end. But before I start any of this, I think I need to just say what I'm not going to be talking about. Last week we heard a great presentation about public health, about epidemiology. I'm not going to be talking about any of those things. I'm not going to be talking about what you can do to prepare your intensive care unit, either for the first, second, or third wave of COVID. I'm going to be talking purely about how to look after the individual patient in front of you in the intensive care unit according to the usual standard that should apply in intensive care. In many areas of medicine, it's unclear what the standard should be. But in intensive care, the standard is very clear. It's the standard that you would accept if your child or your parent or your spouse was in the ICU. So this talk will assume that there are no resource constraints, which I realize is not relevant to large portions of the world at the moment, but that's what I'm going to try and tackle. So we know that COVID in hospitalized patients, has a proportion of them will require intensive care. And that proportion will vary, of course, depending on how sick the hospitalized patients are. And it also depends on where you look in the world. In Singapore, we're looking at toward the 5% mark. In other parts of the world, like New York, it may be in excess of 20%. We know that COVID predominantly causes a pneumonia, but that's not the only organ system it can affect. Particularly in more advanced forms of critical illness, myocardial involvement is extremely common. But in my experience, it's usually relatively mild. We have either biochemical or clinical evidence of myocardial involvement, but the dominant problem is respiratory. We also have seen a substantial increase in hematological complications of ECMO, in particular clot or thrombosis. And that has been causing a higher proportion than we would expect of clots in the lung and of stroke. And lastly, in ventilated patients, we see quite a lot of kidney injury. Perhaps 20 to 30% of ventilated patients with COVID are requiring at least short-term dialysis. COVID does affect other systems, but those are much less common, and I won't be focusing on those. One of the dominant features, of course, of COVID in the ICU, and in fact in any hospital, is how contagious it is. So the apparent contagiousness of COVID has forced people to become very innovative. And we've all seen the news from overseas from healthcare workers dying from occupational exposure to this. And personal protective equipment, even in those parts of the world that have large stocks, large reserves of this, it obviously behooves us to use them responsibly. So people have started to become innovative. This is one example from a colleague in New York. You can see that all of the technical equipment is in fact outside the room and run under the door. So the nurse can make adjustments to medication administration, fluid administration, or minute-to-minute changes in ventilator settings without needing to gown into personal protective equipment or expose themselves to the risk of transmission from a minute-to-minute basis. So now I'm going to go through those aspects of intensive care, those life support modalities, to just explain what we can do. So assuming that the patient on the general ward is managed just with supplemental oxygen, either through a face mask or nasal prongs, if they're admitted to intensive care, this is the first option that we would go for. Now, I should say that not every institution will do this, because there has been some concerns that the first two devices I'm going to share can increase transmission of the virus. So they're not closed systems, and they could potentially aerosolize the virus and therefore increase transmissibility to healthcare workers. And initially, there was a lot of reluctance to use these devices for that reason. Nonetheless, as experience and comfort has grown with this disease, other societies, such as the National Institutes of Health in the United States, have recommended that this be the first port of call. Why? Because it provides more effective oxygenation than conventional supplementary oxygen, and it is much more comfortable for the patient. As we go through this kind of hierarchy of life support, the invasiveness and the discomfort that it exposes the patient to increase, but in turn, it gives us more ability and more control over the patient's physiology. So these high-flow oxygen devices, pretty simple circuits, they run between 50 to 60 liters per minute of an air-oxygen mix directly into the patient's airways. In children, that's about 2 liters per kilogram per minute. And that kind of flow rate will raise the pressure in the patient's airways slightly above atmospheric pressure to about 4 to 8 centimeters of water. Now, we don't, in routine clinical practice, measure that pressure, and that's one of the weaknesses of this system. We can't titrate it or adjust it. We set the flow, and then we can adjust the oxygen. But as I say, the best thing about this is that it's more comfortable for the patient. If that is unavailable, or if the patient can't tolerate it for whatever reason, the next step up is this. So this is non-invasive ventilation. You can see in the background that you have a ventilator custom built for this purpose. The interface between the patient and the machine is a mask. There are a number of different kinds of masks. The principle being that they have to be airtight. And it seems perhaps that this wouldn't be too intrusive initially, but if you have this blowing in your face for several days on end, a lot of patients just can't tolerate it anymore. It does apply pressure, which we can control and monitor, as well as being able to titrate oxygen. If you look at those series of intensive care patients in whom both of these have been tried, both high flow nasal cannula and non-invasive ventilation, there is a substantial failure rate. So a lot of the patients, in some studies, the majority of patients, this has been tried but failed. And that has led clinicians to take patients on to the next step, which is invasive ventilation. And here we see a mock simulation of the interface now between the patient and the machine being a tube, which is placed through the mouth across the vocal cords into the windpipe, which is clearly uncomfortable. It's usually placed under a light general anesthetic. And thereafter, the patient needs to be sedated to tolerate this invasive medical device. And therefore, the treating intensive care team have to take over more of the patient's day-to-day needs, such as nutrition. The advantage of this is that we now can lower metabolic demand through sedation, and we have much greater control of the patient's physiology. Nonetheless, this comes at a price. The ventilator it can provide certainly up to 100% oxygen, and it can increase the pressure, but this pressure can become detrimental if it's taken to excess. It not only can cause abnormalities in the circulation, but it can also damage the lung, in some cases permanently. So what do we do if the patient is deteriorating despite invasive ventilation? Well, the first port of call that we would go to is this. So this is a very simple maneuver. There is very strong evidence supporting it. We have randomized controlled trials illustrating that for moderate or severe respiratory failure in ICU, nursing patients in the prone position not only reduces the need for other forms of life support, it also reduces mortality. Nonetheless, there have been further studies on this, which shows that the uptake amongst clinicians has been very low, particularly in North America, as low as 15%, whereas I would argue it should be closer to 90 or 100%. There are a number of patients who you cannot prone, such as those with spinal cord injuries or pregnant women in the third trimester, but most patients can and should be proned. We heard a couple of weeks ago that awake proning, so before even putting the tube in the patient's windpipe, we can use proning as a maneuver because COVID seems to preferentially begin at the back of the lung. And by putting the patient prone, just the effect of gravity on the blood going through the lung makes the lung function more efficiently and increases ventilation to perfusion matching. So proning is certainly something that we would always recommend, and it's something that we would insist upon before we escalated to the next, and in my view, the final form of life support. And this is ECMO, or extracorporeal membrane oxygenation. I hope you immediately get the sense that this is more resource intensive and more technically complicated. ECMO is not something that any one individual can do by themselves. It requires a team, and it requires a specially trained team. The components of that team, obviously you need trained nursing staff. If you walk into the room in which an ECMO patient is being nursed, you may seem, well, it seems pretty straightforward. But if you then have a machine that suddenly stops working, when 80% of the patient's cardiac output is going through this machine a minute, the patient can be dead in less than a minute unless you have trained staff at the bedside 24/7 to be able to address this. Technical failures like this do not happen very often. They're very unusual. Nonetheless, they do still happen, and every member of the team needs to be trained in order to be able to handle this. So the nurses provide constant expertise. We also have the expertise of a perfusion team, so they're experts in cardiopulmonary bypass who provide additional technical support. We have surgeons in Singapore. Those are usually, in fact, always cardiac surgeons who put these cannulas in to facilitate ECMO. The cannulas we need to put inside the patient in adults are about 1 centimeter in diameter. So those occupy the jugular and the femoral veins. And you can imagine having a 1 centimeter catheter in your jugular vein. You want to have somebody who can put that in very skillfully. And then lastly, we have intensive care physicians with special training in ECMO who know how to deal with the interface between the patient and the machine. This is a much simpler schematic of how ECMO works. Yes, the mannequin in question is an infant, but it applies equally well in older patients. So we're taking deoxygenated venous blood outside of the body, which is the extracorporeal bit. we're pumping it through an artificial membrane lung, where oxygen goes into the bloodstream, carbon dioxide comes out of it, and then it returns back into the venous system as an artificial lung, or it can go back into the arterial system of an artificial heart. There are various other configurations which I don't propose to get into. They're used very rarely. And in COVID, the vast majority, more than 90% of patients going on ECMO for COVID are requiring veno-venous ECMO for respiratory support. This is a photograph of another kind of ECMO circuit. You can see deoxygenated blood coming in at around 7 o'clock towards the pump in the center of the screen. You can see it going into the top of the oxygenator, and you'll notice that there is a color change in the blood. As it comes out of the oxygenator, it looks much brighter, and that's because the oxygenator is functioning properly. Here we have another picture of the oxygenator at work, and I hope these pictures are giving you the sense that this is complex medical equipment that you want trained staff to look after. This is not something you can just walk into the room and intuitively know how to fix. It's not like an iPad. But this is the advantage of ECMO. So this is a young woman whose lungs are completely full of fluid. She's impossible to ventilate mechanically. There's no air going in or out of her lungs. And obviously without ECMO, she'd be dead. The owner of this particular chest x-ray, I'm pleased to report though, did make a complete recovery and was home 2 weeks later. But if it wasn't for ECMO, she wouldn't have survived. So it's rarely needed, but when it is, it's life-saving. Just briefly, a few more technical details on how it works. This is the oxygenator we saw previously. This time it's been cut in half. You can see the blood flow path comes down at the top in the middle where the heat exchange occurs, and then it executes a hairpin bend, goes back up through this meshwork of hollow fibers where the gas exchange takes place and back into the patient. We can see in this schematic, you can see the blood washing over these fibers. These fibers are about 0.5 millimeter in diameter, made of a special substance called polymethylpentene. The name is not important, but the function is vitally important because these fibers are completely impermeable to liquid, but freely permeable to gas. So that means oxygen can get in to the bloodstream and carbon dioxide can get out of it, but the blood has no interface with the air-oxygen mix on the other side of the membrane. Now, have we been in this situation before with an emerging infectious disease and people talking about the use of ECMO for refractory refractory patients with respiratory failure? And the answer is yes, we have. Back in 2009, we saw the swine flu pandemic. And at the same time, we saw a randomized controlled trial published in The Lancet. It was the first in over 15 years on the topic, which showed that there appeared to be a survival benefit about managing patients with severe respiratory failure in a hospital that was capable of providing ECMO. And as a consequence of this, prior to 2009, adult clinicians usually sneered at ECMO. They said it was either experimental or useless. In pediatric and neonatology, it had been a standard of care for over 2 decades. But in 2009, all of a sudden, the adult ICU community woke up to what ECMO could do. And these are data from ELSO. There was an explosion in the number of institutions taking up ECMO to provide care for their patients. And if we look at adult respiratory failure in particular, you can see there's this exponential explosion in the number of patients being supported on ECMO for adult respiratory failure that continues to this day. Now, I don't want to focus too much on individual studies because it gets too technical, but I have to bring up this one. This was published 2 years ago. It's the largest and best trial of ECMO and adult respiratory failure to date. The reason why it's important for this discussion is people will ask me, well, when do we use ECMO in patients? When do we know the patient's ready to go on ECMO? Because we don't want to put the patient on ECMO if they can get away without it, because it exposes them to unnecessary risk. On the other hand, you can wait too long. And if you wait too long, it doesn't matter what you do with ECMO, the patient's not going to make it. So it's important to pick your moment, and that at the moment really boils down to clinical experience. But this is the best evidence for when we do it. And again, these are technical details which are irrelevant to anybody who doesn't work inside of an intensive care unit. Suffice to say that this is very, very advanced respiratory failure. That was the inclusion criteria for this study. Now, these, I think, are applicable today with COVID in patients who are already in an ECMO center. All of the study, the hospitals in the EOLIA study were very experienced ECMO centers who could move quickly to put patients on ECMO if they needed it. If you are looking after a patient who does not is not in an ECMO center, obviously this process needs to happen sooner. We can mobilize ECMO teams, a cardiac surgeon, a perfusionist, and a critical care nurse to go to other hospitals, put the patient on ECMO, and then bring them back to the ECMO center. But obviously this takes longer, so the call needs to be made earlier. Some of the initial reports coming out of China were of considerable concern. There were small numbers, but they showed that patients treated with ECMO for COVID had more than 90% mortality, which was extremely alarming. And we didn't know whether this was because COVID just was not a disease which could be treated with ECMO, or whether it was because the healthcare systems were using it in desperation and were overwhelmed, and therefore the quality of care that they could provide was not so good. So ELSO in early March stepped in to set up an addendum to the registry which tracked patients being treated with ECMO for COVID. This was a screenshot that I took yesterday morning. You can see there are now over 1,000 cases that have been reported to ELSO. There are far more cases of COVID patients being supported on ECMO that are not captured by this registry, but this is probably the largest, or certainly one of the two largest series to date. This has not been published yet or peer-reviewed, but it does give a sense that those patients who have either passed away or survived to hospital discharge after being treated with ECMO, roughly 50% are doing so. So this gives you a sense of what ECMO may be capable of. Stepping away from ECMO for a second and just looking at wider outcomes, this, again, there are many studies on this. This is one from New York published in The Lancet last week. You can see from looking at these curves that it is a disease which affects predominantly middle-aged and elderly people. Some of the elderly people in question may not have even been admitted to intensive care, but you can see that the older you are, the worse that you do with this disease, which might make some people ignore the disease in children. Unfortunately, this would not be prudent. In the last few weeks, we have seen an emergence of a new syndrome. It has various names. There are at least 5 names combining multi-system inflammation and pediatric. I don't think that any of them are particularly satisfactory, but it's very akin to a disease called Kawasaki's disease with shock. I was just talking to a colleague in the United States a few days ago who works down the road from the CDC in Atlanta, and he said that his hospital has 36 of these children in there at the moment, which I found absolutely astonishing. I didn't realize it was that common. But I think with all of this unrestricted community transmission in places like the United States and Western Europe, we're going to see this more commonly. Thankfully, it can be treated similarly to Kawasaki's with intravenous immunoglobulin and supportive care. And yes, you can use ECMO for that too. This is not a child with COVID. This is a child with Kawasaki's disease and shock syndrome. And again, it just shows how intense the therapy that these children require to pull through. This particular child actually has the ECMO cannulas directly implanted in the heart. And there is some evidence in children with shock that outcomes are better by doing this. So in conclusion, at present, we have no proven therapy for COVID. There is a drug called remdesivir, which shows some promise, but it's premature to conclude whether it has a substantial mortality benefit, particularly in patients who are critically ill. So for the meantime, treatment remains largely supportive. So we rely on these life support devices to try and keep the patients alive until their own bodies can clear the disease. So it really becomes a race against time. So I'm going to stop there. Thank you very much. And back over to you, David.
Great. Thank you so much, Graeme, for that was an excellent review. And I do want to remind our viewers to please send in your questions. We need to have questions so that we can suss this out. And I'm going to take the moderator's prerogative and ask the first question. You mentioned that with COVID, and this isn't an ECMO question, but with COVID, that approximately 20 to 30% showed up in the intensive care unit with acute renal insufficiency. I'm just wondering, in your general ICU population, non-COVID, what percentage of your ICU population is acute renal failure?
Well, that's a difficult question to answer because it depends on why they're in ICU. If you look at patients with septic shock, yes, acute kidney injury requiring dialysis is very common in that group as well. So whether or not the pathophysiology of COVID is different, we don't know. We know that it seems to have worse outcomes in patients with pre-existing vascular disease, diabetes, obesity, and these in themselves can cause kidney dysfunction. So it's hard to see at the moment. Another problem with this, of course, is that we're trying to assess a moving target. There is an urgency to get important medical information out to the community, but on the other hand, we're taking shortcuts. So we don't have 90-day outcomes for a lot of these patients. we have 28-day estimated outcomes, which makes a lot of this data very preliminary and hard to comment on.
Good. Great, thanks. Caitlin, do you have questions for us?
Yes, Dr. Allen. Our first question tonight is, what, in your opinion, is considered an acceptable ECMO success story? What is an acceptable outcome other than survival? And does this factor into patient selection?
Yeah, so that's a great question. Historically, what we looked at was in-hospital survival, which is a very easy thing to capture. The problem is it doesn't tell you in what state the patient leaves the hospital. Some further follow-up work that's been done, particularly in children, has shown that there is an attrition rate. So if you stop looking when the patient goes home, you're not going to capture all of the adverse outcomes. So for some conditions, particularly after ECMO, you will see a late death rate. And for most conditions, it's around about 5%. So in-hospital survival is not enough. You need to look longer. And there have been some calls at looking, for example, at 1 year. So 1 year survival, but even that's not enough. Because again, it doesn't tell you anything about morbidity. So there has been a push, again, particularly in pediatric intensive care, to try and establish a new ECMO standard follow-up, which is 1 year survival with good outcomes, both quality of life and neurological outcomes. And to me, that's a much more satisfactory, although harder to capture, outcome measure.
The second question is, to what do you attribute Singapore's very low COVID-19 related case fatality rate? Are we seeing the same disease as other countries?
Again, I think it's difficult to compare results between different countries. We have some experience of this about comparing intensive care unit outcomes in the same country. And there's a number of different ways to statistically adjust for that. You have standardized mortality ratios and various forms of risk adjustment, and people aren't in a position to do that yet. I think there's a number of factors which are influencing mortality in the intensive care unit between countries, between communities. First of all, there's the issue about comorbidities. So we know, for example, that the comorbid diseases in inner city Queens are going to be different from the comorbidities in Singapore or South Korea or New Zealand for that matter. There may be higher incidence of diseases like lung disease, heart disease, diabetes in some communities more than others. And we know that this virus has a predilection for causing more severe illness in them. Another issue is the issue of the quality of the healthcare system. And again, this is not meant to be a criticism. One of my, I think one of the most satisfactory metrics, if you're trying to analyze the quality of a healthcare system, is how well they look after the most vulnerable people in their population. And one of the best doing that is the under 5 child mortality rate in a country. So it's the number of children usually expressed as per 1,000 children who reach to see their 5th birthday alive. And for the last 2 decades, the winners in that category up until very recently were Singapore and Luxembourg. And I don't think that's a coincidence. Both of them are very small city states. Both of them have a well-educated population with comfortably resourced, and everyone lives within a short distance to medical attention. So I think that probably is playing a part in the response. And then lastly, of course, is the governmental response. It's not just to the healthcare system. The government has in Singapore had a very tight response to this. And, this phrase, flattening the curve, has entered the vernacular, but it's true. We haven't seen this kind of overwhelming influx of COVID patients into our hospitals as they have seen in other parts of the world. Singapore was prepared for it, as many other countries in this part of the world have been. So hard to answer question again, and I don't want to speculate too much, but I think those are some of the reasons behind it.
The third question is, you were cautious about the role of ECMO in a February 2020 JAMA editorial with co-authors Dale Fisher and Daniel Brody. Has your position changed since?
Yeah, I think it has. The purpose of that editorial was to try and anticipate the needs, the requirement for ECMO. And the 2 things we wanted to really get across, one was at the time we knew nothing about the natural history of the disease. We didn't know whether there were late complications associated with it. We didn't know how many patients were dying for reasons other than heart or lung failure. ECMO will support the heart and the lung. It doesn't support the brain. It doesn't support the liver. So we didn't know what proportion of patients had these organ systems affected. The other thing that we wanted to get across was a point really made by Dale, because of his work with the WHO. And in earlier disease outbreaks, some people had approached him saying, oh, we have to get our ECMO programs up and running. And we wanted to make the point that this is not the time to do that. ECMO, as I hope I've demonstrated, is very, very expensive, resource-intensive therapy, which requires a skilled team. You can't just decide, oh, I'm going to do ECMO and let's start tomorrow. It needs to be something that's part of the daily currency of your intensive care unit before you want to apply it to COVID patients. There are additional complexities in COVID patients related to the transmissibility of the virus and the dangers to healthcare staff, which do affect our ability to give ECMO. So it's not business as usual by any means. We still don't know enough about the disease, but I think more data are coming.
And I'm going to jump in. You just alluded to it a little bit, but I want to expand on this a bit. What volume of ECMO patients is necessary for a center to maintain excellence? Are tertiary centers able to maintain that volume in non-pandemic times?
Yeah, absolutely. So this is a controversial area. It's a very sensitive area because, you know, if I work in a small volume ECMO center and you publish data to show that bigger ECMO centers have better results, then I can take offense at that because you're saying I'm not doing a good job. And the data are not by any means cut and dry, but there is a signal in the literature that if you're doing ECMO more than X number of times a year, you have better outcomes than if you're doing it only a handful. Now, as I say, there's a number of studies. Most of them are pediatric. The best study to date was published 5 years ago using the ELSO registry, and it categorized centers into low, medium, and high volume centers. And high volume was defined as more than 30 cases a year. And both adult ECMO centers in Singapore have comfortably in excess of that. So at least here, I think we have a system in place to handle this issue about volume and outcome.
And the next question is there concordance amongst various professional organizations about when to offer ECMO?
There is evidence to support certain views, but it is still, there's a lot of individual variation. And if you lined up 100 ECMO experts, you probably get slightly different views. So as for other international societies, the arguments are usually, does ECMO have a role to play rather than when should you use it? Because again, it's hard to just come up with a bunch of numbers and say, oh, if the patient meets these criteria, then go for it. It's more complicated than that. You also have to think about how quickly the patient is getting worse. So if the patient was, you know, running around in the community 6 hours ago and now they're all of a sudden on a ventilator and they're rapidly deteriorating, you're going to have to move much faster than if they've been stable in the ICU for the last 3 days. So there's a lot of factors, and we don't have a fantastic evidence base to say this is the time that you must put patients on ECMO.
So you've also touched on this as well. I'm just trying to get, I'm interested in the patient selection criteria and the ethics of offering this very expensive, very invasive procedure. How is that decision made? I mean, do you take every patient that is failing conventional support?
We don't take every patient. No, I think you have to be careful in who you select. And, you know, if you see what happens to those patients who, you know, bad luck gets to them, or it was a judgment call, it was a difficult decision, the decision was made to go on ECMO, but it didn't work out, you know, it makes life difficult for the patient because it prolongs their death and it prolongs the suffering of their family. And it's, you know, a huge investment of time and effort. And all it does is prolong suffering. Then we haven't done the right thing. And again, that boils down to experience. But we've learned to be relatively selective. In the last couple of years, Ministry of Health here have made both ECMO centers come together and agree on what criteria we should use to put patients on ECMO. So at least we have some formal criteria which to guide clinical decision making.
Great. Has anticoagulation for ECMO changed due to the endothelialitis and thrombosis seen with COVID-19?
Again, too early to say. I think some populations seem more affected by this issue than others. I have colleagues in Western Europe and America who have had terrible troubles with the ECMO circuit clotting and with clots going to the lung or with the patients stroking out. My experience in Singapore with ECMO patients has been, yes, it's an issue. It's more of an issue than it is in patients with other forms of viral pneumonia. And it requires you need to maintain a flexible stance and think on your feet. And it's a question of picking which is the major problem that's going to cause problems to the patient. Is the patient bleeding more than they should, or are they clotting more than they should, and stacking your therapy towards one or the other?
What are the contraindications to ECMO?
So that varies by the age. If we're just focusing on adult patients, the main concern is if we're dealing with an irreversible lung disease that transplantation is not a problem for. So again, Singapore doesn't have a large lung transplant program. So we'll have different contraindications criteria to certain centers in North America who can transplant patients directly from ECMO. Even then, there are certain conditions that you can't do that. Like disseminated tuberculosis, for example. If your lungs are destroyed from tuberculosis and it's still growing in culture, you cannot be transplanted. So that's not going to work. So the guiding principle here is, A, if it contradicts common sense, then don't do it. So if somebody's dying of metastatic cancer, then what are you trying to achieve by putting them on ECMO? If they've got catastrophic neurological injury, what are you trying to do? But the guiding principle is if you have got irreversible lung disease, then don't put them on ECMO.
What is it that ECMO does to allow or promote lung recovery? Is it proven or speculated?
Oh, I think it's somewhere in between. So there are two things that ECMO does. One is it keeps the patient alive. I mean, you saw that chest x-ray I showed earlier. That patient will not survive without ECMO. The other principle that you want to use when you're putting patients on ECMO is to protect the organ that's damaged, whether that's the heart or the lung. And one of the things that damages the lung in very advanced critical illness is the ventilator itself. So if you're using very high pressure ventilation, you will cause lung damage. So ECMO allows us to back off enormously. So we're just what are called rest settings. We're not doing much with the ventilator at all. And that facilitates lung recovery. Now, in the old days, so 25 years ago, common practice was if the patient wasn't clinically unchanged at 14 days of ECMO, they would withdraw care because they would say, oh, the patient's not going to get better. And then investigators in Sweden said, well, where did this number come from? And why are we so confident here? So they started pushing the boundaries and discovered that if you waited 40 days, 50 days, these patients could recover by themselves just by not ventilating them aggressively and treating the underlying disease. And in the last year, we had the longest ECMO survivor to date. So a 7-year-old girl at Johns Hopkins was treated for 604 days of ECMO and has now returned home. So we don't know enough about the regenerative biology of the lung. It clearly has an ability to regenerate itself, but it's very, very new, cutting-edge information that we don't know enough about. But it's very interesting.
It has been proposed that there are two primary phenotypes of COVID-19 pneumonia, L and H, with different pathophysiologies and should be treated differently. What are your thoughts on this?
So I have to tread carefully here. This idea came from a man called Luciano Gattinoni, who's one of the world's most famous respiratory intensive care physicians and respiratory physiologists. And he is, he's a very, very smart cookie. I'm not about to argue with him. So the idea came from him. This LNH phenotype refers to low or high elastance. We don't have time perhaps to get into the technical details, but he was proposing that there are kind of two primary manifestations of lung disease with COVID. Now, whether that's true or whether they're just a spectrum of disease where one can merge into the other is not clear yet. So I think it's a theory, but it doesn't have sufficient evidence to have it accepted as gospel yet.
Let me ask you about, oh gosh, here it is, pros and cons of early versus late intubation.
Yeah, so the easy answer to that question is early. The problem with COVID is because it's so high risk to the staff looking after them, it takes longer than normal. So they have to wear PAPR, so powered air purifying respirators, in order to safely intubate somebody, and that takes time to set up. So you don't want to be caught with the patient suddenly collapsing because you waited too long to intubate them. So again, drawing hard and fast rules about exactly when to intubate, I think, is difficult, but I would err on the side of early intubation because then you're going to establish control safely and not take the risk of exposing your staff or your patient to worsening disease.
Graeme, thank you so much. We very much appreciate your answering these challenging questions and your expertise. And that's all the time we have for questions today. So next we're going to move to Dale's going to update us from current events. And then over to you, Dale.
This week, I just wanted to touch on a couple of things. Brazil, you asked me about a couple of weeks ago, David, so I thought I would catch up on that one. People keep asking, what's the WHO doing? So I thought I've seen some nice graphics from that, and I've got an interesting, important piece of news from Switzerland. So it was a very unusual Lancet editorial that quoted perhaps the biggest threat to Brazil's COVID-19 response is its president. So that certainly grabs a headline, and now people that are not supporters of the president regularly bash pans and pots and pans outside their windows in response to what he's doing, which most don't agree with. So you can see that here he is. This is a rally, a recent rally. He spent a lot of time undermining governors' measures, and a federal judge even banned the government from campaigning against any isolation measures, and that forced the government to take down a lot of hashtags and things against it. But in response to a journalist's question about the record number of deaths from coronavirus, he said, "So what? I'm sorry. What do you want me to do?" And this is part of the problem. These favelas, which contain absolutely millions of people, obviously very overcrowded settings with people with pre-existing poor health problems. Brazil, it's already spread into the Amazon basin, and obviously indigenous people where it's said to be wreaking havoc, and a lot of this is on the border of Venezuela where it might flow in there as well. We see these other vulnerable groups going. Prisons, overcrowded prisons. This photo on the right is just amazing in a bad way. But this is apparently not an unusual thing in South America, and there's been uprisings in several countries, including Peru, Argentina, Brazil here, as well as Venezuela. So that's just a little bit on the problems of Brazil and why, going forward, I think we're going to see increasing numbers of concerns there. Moving on to the WHO, I remember seeing this in January, and I just think it was a great sort of high-level strategic objectives that were promoted at the time about interrupting human-to-human transmission with all these public health measures, rapid identification, diagnosis and management of cases, follow-up of contacts, IPC, all the obvious things that now it's hard to believe in May we're still talking about this in some countries. Many countries still not doing a lot of isolation of the patients. And this one's interesting: identify and reduce transmission from the animal source. And countries are still protesting, saying we have to investigate the origins of the virus. And here it is. It's always been part of the plan, and as if we weren't going to do it. I'm not sure how you do it now, because some work has shown that 15% of the cats in Wuhan are carrying the virus. So maybe there's your mammal transmitter already between the bat and the human. We know lots of dogs. Months ago, the dogs in Hong Kong were found to have it. So anyway, just some points there on what the strategic objectives have always been. And here's a little bit more deeper level. As of May the 1st, these are the PPE that's been provided, and through various consortiums to create more PPE. You can see the pipeline that's planned and is being implemented now. So they do deliver a lot to needy countries. and delivering 1.5 million diagnostic kits to 129 countries. So, and another 30 million tests are on order. Building the capacity to respond, 65 learning resources in 21 languages, more than 2.5 million people have seen these. So this is a major commitment of WHO is to review the evidence and create the community engagement to ensure that the information is best provided, and that can either be to the public or through technical guidance, and a lot of us are on guideline development groups and things like that, which assist in the writing of all these. So really, if ever you've got a question, you can go on the WHO website and you'll almost certainly find a review of all the available information on that, and these obviously also get updated regularly. Creating a global research map, a lot of coordination of the critical questions. Obviously, there's a lot of research happening without WHO, but you can just see through there how this has all been, I guess, enabled through WHO mechanisms to get a lot of this happening in all the various aspects, and of course the solidarity trials, which involve over 100 countries and thousands of patients, consolidating work on trials in both treatment and vaccines, focusing on the big questions, which you can scan down here and see, and it's quite thorough. So that was a brief one on Brazil and WHO, and just finally in Switzerland, you can see, like most countries, especially in Europe, that they're opening up a bit and allowing more things. 30 people in gatherings, 300 people in events and demonstrations, training campsites. You can see all these sort of things are happening, but as you look a little bit closer, you go, what the hell is this one? And congratulations, on June 6th, the sex workers are allowed to go back to work. So I thought that was an interesting little priority given to the opening up after a lockdown. So that's all for me this week. Thanks. Back to you, David.
Thank you, Dale, very much, as always. We appreciate it. And it leads me to thank Graeme MacLaren for his contribution this evening. We very much appreciate his expertise. And now I will preview next week's speaker, who is Professor Audrey Chia. She's Director of Leadership Development Program, Associate Professor of Management and Organization at National University Singapore, and Joint Associate Professor at National University Singapore Yong Loo Lin School of Medicine, as well as Chair of the University-wide Master of Science in Environmental Management. Her research lies in the intersection of business, medicine, and environment. She'll be examining the COVID-19 pandemic from the perspective of leadership and asks, how have we done? What can we do at present? And how can we prepare for the future? The title of her talk will be Leadership and Intervention for COVID-19 and Beyond. There is a chat box tool at the bottom of your screen. We would appreciate your feedback very much. The chat box will be open for another 10 minutes or so. So we do encourage and welcome your comments. Until next week, stay safe and wash your hands. In honor of Little Richard's recent passing, we should follow his instructions for social distancing when he reminded us that I hear you knocking, but you can't come in. Good night.